Urinalysis, ladies and gentlemen, also known as a urine dip. What exactly is the idea? What are we looking for? And what does it mean? So let's appreciate first and foremost, urinalysis or urine dipstick testing is validated and endorsed by NHS England. It is a very reliable, very cost-effective and very accessible, easy to perform test that can be classified as a point of care test or bedside test. It is widely used in general practice, primary care settings in the NHS in the UK, as well as secondary care settings such as the hospitals, including the ED, i.e. the emergency department or A&E. And of course, in tertiary care settings like hospices. So how do we perform? What do we do? Essentially, the patient provides a urine sample and the urine sample is dipped with a test strip. The test strip comprises of a number of pH sensitive papers, a bit like a litmus paper, and they change colour, just like your litmus paper change colour in the presence of acid going from blue to pink. In a similar fashion, this is what the urine dips do as well. Analysis of these urine dips can be subjective or objective. In primary care and some hospices still, they will analyse these subjectively, i.e. the practitioner, the clinician will analyse this. Whereas in the hospital setting, this is largely done by means of digital analysis. So a machine will analyse the test strip for you. Of course, this is also changing in general practice and hospices to become more digital, so as to ensure greater consistency as well as objectivity. Now let's just appreciate very briefly how urine is made. Appreciate that urine is initially made from the kidneys, of which there are two, the right and the left. The right kidney is lower than the left because the liver sits just above it. The functional unit of the kidney is the nephron, of which there are about 1 million in each kidney. 85% or so are medullary, and about 15% of these nephrons are juxtamedullary. The nephrons will, the kidneys rather, will pass the urine down a pipe each. So if here's where the kidneys are, that is connected to the bladder by means of a pipe known as the ureter. There is one ureter on each side, and the bladder is essentially a vesicle. It is like a funnel. It is a muscle known as the detrusor muscle, which holds the urine, and when it is stretched enough, it will instigate the micturition reflex. So once it's stretched enough, because it's filled enough, it will stimulate a response asking you to go for an episode of urinary voidance. At the bottom of the bladder, you find the urethra, which is the little pipe that transfers the urine from the bladder to the external environment. That's the generative urinary tract. Ultrafiltration is a process of pressurized filtration, and the glomerulus sits encapsulated by the Bowman's capsule, also known as the renal capsule. That goes on to become the nephron, so all the various components of the nephron emptying into the collecting duct and into the renal calyces. Now let's move on to the actual components of urine. Urine should comprise of nothing more than water, urea, creatinine, sodium and potassium, alongside negligible amounts of other ions, what we call trace amounts. Anything bar from these is abnormal. It should not be present. So if we go back to the glomerulus, for example, this is essentially a blood vessel which is fenestrated, i.e. it contains pores. If there is damage to the glomerulus, then larger molecules will pass through the small pores as well, the fenestrations. These may include red blood cells and proteins such as plasma proteins and albumin, as such, or even glucose molecules. As such, we may find these present in urine, and so therefore this may cause, this may be detectable on the urinalysis, or otherwise visible to the naked eye. So let's have a look at what urine should look like and what it may look like in the presence of dysfunction. So urine itself should be pale, straw-coloured, odourless. It should have a pH of around 4.6 to 8.0, so slightly acidic. Remember, neutral is 7. The higher the pH, the more alkaline it is. The lower the pH, the more acidic it is. If the urine has a hint of red colour to it, that may be the presence of blood. Blood in the urine is known as hematuria. If it is visible to the naked eye, this is known as macroscopic hematuria. If it is not visible to the naked eye but detectable on urinalysis, this is known as microscopic hematuria. Causes of macroscopic hematuria may be the presence of a renal calculus, i.e. a kidney stone, as it passes through the tract and causes damage. It could be a UTI, or it could be some nasty things such as cancer of the prostate gland or bladder cancer itself. Microscopic hematuria may be present in the context of a UTI, or situations where, for example, you might have glomerulopathy, so dysfunction of the glomerulus, also otherwise known as nephropathies or other types of nephropathies. If the urine itself is strong and in terms of its yellow colour, and there is a strong smell to it, it is foul smelling, we may consider UTI. But the first thing we should consider in this situation is dehydration. Remember, we lose about 2.5 litres of water on a daily basis through the various modes, and therefore we should be drinking 2.5 to 3 litres of water on a daily basis. And so therefore the first thing we should ask the patient is, are you well hydrated? If so when we obtain a urine sample, what we might want to do is eyeball the sample first to look for the strength of the colour, and you may even get a whiff of the smell. Strong smelling, like I said, and strong looking, maybe dehydration or UTI. A red hint may indicate hematuria. If the urine sample is milky in colour or in consistency with a bit of a precipitate, that may indicate the presence of albumins, which is one of the proteins found in plasma. If the urine is frothy, this may indicate proteinuria, so albuminuria or proteinuria. And both of these may indicate dysfunction at the liver, because this is where plasma proteins are largely synthesized. If the urine the urinalysis demonstrates the presence of glucose in the urine, then we may consider the possibility of diabetes in the patient. That is what we call glycosuria. If we have ketones present in the urine may smell of pear drops or acetone, which is found in nail varnish remover. Ketonuria may also indicate dysfunction at the liver because of dysregulation in the breakdown of lipids. You may find urobilinogen in the urine, and again this may indicate dysfunction in the hepatobiliary pathways or the hepatic pathways in its entirety, i.e. the liver dysfunction. And finally, you may have tea-coloured urea, and tea-coloured urea may indicate the presence of myoglobin, what we call therefore myoglobinuria. And myoglobin may be present in urine in situations where we have skeletal muscle breakdown. Conditions for this may include the likes of rhabdomyolysis. So there we have a number of different reasons why we might have discoloration or abnormalities in the urine from the norm. Finally, what we might consider here is urine dipstick should not be performed in patients over 65 as per the guidelines from NICE, the National Institute for Health and Clinical Excellence. The reason for this, or rather let me correct this actually, urine dipstick should not be performed in this age group over 65 as per NICE guidelines if we are suspecting urinary tract infection. If we have other reason clinically justified and we are trying to identify other findings, then it is absolutely clinically validated and plausible and reasonable to do. But if you are suspecting a UTI in patients over 65, a urine dip should not be performed. Rather, we should rely on the clinical history and the clinical presentation. The reason for this is because there is sufficient evidence that suggests the lack of reliability in detecting bacteremia in this patient group. Thank you for watching.